Coming last after a mostly Italian audience is not easy. I already took that a bit into account and reduced my slides so that we at least have time for your questions. Um, Consider what I'm going to say more as an overview of what technology can bring us, and hopefully where we will end up is something what the other speakers already clearly shown you the way forward. I'm going to give you a bit of more of a historical overview of what where we've come from and what impact that already had. So I'm going to discuss a bit the evolution of planning techniques, going from 2D all the way to SBRT, how that accompanied motion management, and also that resulted in quality of life improvements, or at least improvement in side effects. So if you look at the technology evolution over time, we started with 2D, went up to 3D, IMRT, VMAT, and now SBRT. And there are different steps that were required, and I believe it's impossible to go to SBRT if we don't take into account not only the planning technique, but indeed also the inter and intrafraction motion, which I will come back to later. And with that, of course, the margins. So if we go from 2D to SBRT and just look at the dose, these are data from the randomized trials. We can clearly see, just looking at the dose to the rectum, bladder, femoral heads, penile bulb, that if you use an SBRT technique, often even giving a higher dose, you do result in a lower organ at risk dose because your planning technique improves. And often also the margins were a bit reduced. So it's a double action you can see here, but at least the net effect is less dose to organs at risk. So that's a natural evolution we've seen. Question, of course, is does that result in better outcomes? Now, if you take a look at the first evolution that was pioneered by the UK group led by David Turnley, and going from 2D to 3D, indeed, you see an enormous reduction in grade 2 bowel toxicity, almost divided by half. If you move towards what we most often do, IMRT or VMAT, we again see a further reduction in those side effects. And the most recent reports, looking at, for example, PACE-B, and I'm really looking forward to Astro and an update of the NRGG5 study, if that is confirmed, that we almost see a non-existing bowel toxicity, which is quite amazing. If you see that we're coming from around 55% to below 5%, that's factor 10 reduction in toxicity, which is enormous. And this with the evolution of technology. If you just compare that to, let's say, surgery with radical prostatectomy, you see the introduction of the robot. Well, nothing really improved except blood loss, which for the patient is pretty irrelevant. So here we see something which is patient relevant, and that's reduced side effects. And the dose escalation perspective was also highlighted, where if we now go for focal boosting, giving a higher dose to the area of interest, either being on PSMA or PET, whatever, or MRI, whatever you want, you again see an increase in the biochemical and disease-free survival in the update also now published in JCO. So we are not only reducing the dose to the organ at risk, in the same time, we are escalating the dose to the tumor. So we're seeing reduced side effects, improved outcomes, and which is the ideal therapeutic window, of course, what you want. So if we see that impact, we see an impact in efficiency. Of course, treatment times are reduced, patient discomforts are reduced, and an improved throughput through our departments. We see reduction in bowel toxicity, and for prostate, we see better outcomes biochemically and also clinically. If you look at the margins, dating back to 2D, it was at least 10 millimeters in all directions, sometimes even 15 millimeters, going down now to potentially zero margins in the most recent studies, where you want that very high dose escalation. You can't do that very high dose escalation when you use these very large margins, simply impossible. So if you look at that technological evolution where we're coming from, well, we used bony landmarks. We moved to cone beam, we moved to some sorts of tracking and real life adaptation, as Filippo nicely demonstrated. And probably that last aspect, that adaptation is required if you really want to go to that zero margin or minimal margin concept. The first study is done here on image guidance, and to see if image guidance has an impact was daily cone beams versus weekly orthogonal imaging. But do mind, this was a 3D era, so no IMRT, no VMAT. And here you do see in this column all the doses to the organs at risk were reduced, but nevertheless, there were no differences in bowel outcomes, urinary outcomes, and no difference in oncological outcomes. If you look a bit in a more modern concept, this type of trial was repeated where you go from daily to weekly IGRT, but you use the same margin. So a bit of an honest comparison where you just, the only variable where you play with is the image guidance. And here you do see a difference in the rectal toxicity mainly, but also an improvement in biochemical progression-free survival, which was, I think, fairly interesting. And this for me is an argument that daily IGRT is a must in our patients. This was also an sub-randomization within the CHIP trial, and many have missed this trial. So within CHIP, you had the conventional fractionation versus the moderate hypofractionation, but there was also a sub-randomization for patients, and a group got no IGRT, standard IGRT, or reduced margins IGRT. And looking at those results, you see that bowel side effects and urinary side effects are clearly better when you do your more advanced IGRT with reduced margins. So here you see that the combination, it's not only IGRT, if IGRT is accompanied with margin reduction, you end up with the most promising results for your patient. So not only dosimetric, but also clear clinical impact here. Then if you look at the Mirage trial, this is a margin reduction trial with very high doses, so real dose escalation, 40 gray and 5 to the PDV, which is higher than many of the other trials. You can see that the GU toxicity was better with the dotted line, which is the MRI, which uses 2 mm margins, versus a CT approach, which did use 4 mm margins. So there's a difference here in the type of IGRT that is done, which some might say is a bit of an unfair comparison. It might be that if you do your CT with 2 mm margins, you would end up with the same curves. Of course, that was not the goal of this trial. Here it was to show what MRI can get you to, and Amar Kishan argues that going safely to that lower margins, you do require MRI. But that's something up for discussion. But nevertheless, a concept, again, showing you margin reduction, again, improves our side effects. The same was seen in quality of life, but not in the urinary function, which I think makes sense. You probably need to do some form of urethra sparing, but here that was not performed. Well, we did see clear benefit in the bowel, and also the sexual functions, which was an interesting as well, and also demonstrated how you can do that by Filippo in the beginning. So the impact from IGRT clearly on toxicity. If you use IGRT, you reduce your margins, you lower your dose to the rectum and bladder, and that results in less toxicity. From an outcome perspective, IGRT allows you to increase the dose to the target and might result in better outcomes. Just think flame, think potentially Mirage, and we will be looking forward to that clinical updates later. And that next step then is adaptive radiotherapy, and this is a bit of a time scale. Where does adaptive radiotherapy sit? And it, of course, can take into account both the intrafraction and interfraction changes. So that's the most advanced form. And it was better shown by Filippo again, but here the concept is clear that if you adapt to the situation of that day, you will end up at least dosimetrically with better results. And if you look at a comparison of the toxicity of PACE B grade 2 or higher versus what has been published in Momentum, you do see that in the Momentum collaboration, which all uses the MRI system, you see a lower rate of toxicity. Of course, indirect comparison, but already a potential hint. And I hope there will be future trials that will be randomizing and reporting the results of daily adaptation with, for example, MRI versus not doing that. That is the type of trial we would need to prove that adaptation makes sense. So as a conclusion for this part, toxicity, indeed, margin reduction is possible. Reduced doses to organs at risk is possible, and you might have reduced toxicity. And the short-term results are very reassuring, but here we need longer-term follow-up. And an important one not to forget is the impact of the patient and the situation where you start from. And if you look at the PACE results, PACE B, an interesting subgroup analysis showed that if your baseline IPSS is a bit too high, you have an increased odds of having urinary toxicity. Also, if your patient takes urinary medication, you have an increased odds of having more radiotherapy-related complications. So if you have a patient that starts off bad, be aware that those are the patients that will tolerate radiotherapy a bit worse as compared to patients that have no voiding issues, no medication at start. So your ideal patient will have a lower probability of having side effects. And for example, some centers use IPSS or a Euroflow to determine should the patient get SBRT, yes or no. For example, our center uses the Euroflow cutoff of 10 milliliters per second as a Qmax. If it's worse, so below 10, we never do SBRT. If it's above 10, we go for SBRT. You can use IPSS if that makes you more comfortable, but by doing so, we rarely see retentions anymore. Once we started doing SBRT and not looking at the Qmax, we did end up having patients that go into urinary retention. So for me to conclude, I think improving patient outcomes through technology is possible. You will see not only dosimetrically your planning and delivery, shorter treatment times for your patients, but you will also see reduced toxicity and improved outcomes. But do mind, biology might be king. Improved patient selection might also help you to get the most optimal results. And with that, I would like to thank you, and I give the word back to Thomas.